Hello, my name is Mazen Hanna from the Cleveland Clinic, and I'm here to talk about the orthopedic manifestations in amyloidosis. I'm going to start with a patient story, which we believe is a missed opportunity for an earlier diagnosis. This is a 62-year-old white male who had a history of a hip replacement at age 46, a shoulder arthroscopy at age 52, at age 54, a right knee replacement, at age 55, dual carpal tunnel release surgeries for carpal tunnel syndrome, age 56, a trigger finger release, another hip replacement at age 60, and then bilateral biceps tendon tears shortly thereafter. And ultimately, this patient was diagnosed with wild-type ATTR cardiac amyloidosis and is currently looking to get both shoulders replaced at age 69. And the question is, could we have potentially diagnosed this patient earlier due to what we believe all these orthopedic manifestations were related to the ATTR amyloidosis? So ATTR amyloidosis is known to be associated with multiple orthopedic pathologies, most commonly bilateral carpal tunnel syndrome. Notably, AL amyloidosis can also be associated with carpal tunnel syndrome, but it's more common with TTR. Anywhere from 30 to 50% of patients who ultimately get diagnosed with ATTR amyloidosis, especially cardiac, can have carpal tunnel syndrome. Spinal stenosis, also very common in ATTR amyloidosis, mostly the wild type kind, less so the hereditary kind, but can happen in both. And then biceps tendon rupture. For some reason, there's a predilection of ATTR amyloidosis to the tendons and ligaments, making them more susceptible to injury. And this is a patient with an old biceps tendon rupture. You can see it's like a Popeye arm. About 10 to 30% of patients with wild-type ATTR can have a history of a biceps tendon rupture. Trigger finger, for the same reason that you get carpal tunnel syndrome, all throughout that sheet, there can be amyloidosis, particularly ATTR, and then increased risk of hip and knee surgeries. And finally, mostly newly recognized is a history of a higher rate of rotator cuff tears and shoulder issues due to ATTR amyloidosis. What's classic about these orthopedic manifestations is that they tend to present years before the cardiac symptoms manifest. So someone may have carpal tunnel surgery 8 years before they develop shortness of breath or atrial fibrillation due to manifest cardiac amyloidosis. And the same goes with the other manifestations. We want to focus in on carpal tunnel. You can see deposition of amyloid in what we call the flexor retinaculum, or the transverse carpal ligament, which is right over the median nerve, but you can also see it in the synovial tissue, in the fascia, and even in the vessel walls. We developed a protocol at the Cleveland Clinic where we do surgery and we try to mobilize the median nerve. And when you mobilize the medial nerve, you're able to excise the tissue from around it, and you can ultimately send that to pathology. And this is what you get. You get this, what we call tenosynovial tissue, is like a little blob, and then you send that to pathology, and you can determine if there's amyloid. I would be remiss in not saying that this was all started between an interaction between myself and Dr. William Seitz, former president of the Hand Society, Surgery Professional Society, and this was the original kind of roughened tenosynovial tissue that to him looked like it could have amyloid, and it was sent and found to have TTR amyloid, and the patient ultimately was diagnosed with cardiac amyloid. And so based on this, we felt kind of had the idea to develop a study. So we took males over the age of 50, females over the age of 60, going for routine carpal tunnel surgery, and we did Congo red staining on all the samples removed. And we had 99 samples, and 10 out of the 99, so 10%, came back positive. We typed them as AL or ATTR with mass spectrometry, and then we did extensive testing of their heart at baseline and in follow-up. One example of the positive patient from the study is a 67-year-old white male who had ATTR in the carpal tunnel. Here you can see that the Congo red, this is all the tenosynovial tissue. All this pink stuff is the amyloid. This is the Congo red positivity. And ultimately, the patient had no mutation, so he was diagnosed with wild type. Now, his electrocardiogram was completely normal. His echo showed very minimal increased wall thickness, about 1.2 to 1.3 centimeters. And he had normal, what's called longitudinal strain imaging. Yet, when we did something called a technetium paraphosphate scan, which can be diagnostic of TTR cardiac amyloid, it was very positive. So this patient, without knowing it, already had the TTR in his heart, yet he wasn't symptomatic from it yet, and we started him on medication. This is a 73-year-old white female who was having previous trigger finger and carpal tunnel release. In 2016, she had a left carpal tunnel release, and the tissue removed, staying positive for TTR. And actually, even at her older age, she had a variant called ALA81-threonine, which tends to cause late onset cardiac amyloidosis. This is a nice picture of her Congo red and then also under visualized polarized microscopy, showing all these deposits, which were TTR. What's interesting is when we did the baseline testing in 2016, right at the time of when she was positive in her carpal tunnel, she had no evidence of cardiac amyloidosis. She had a normal echo, she had normal NT-proBNP, she had nothing on that nuclear scan. 4 years later, with essentially very little change in her echo, no change in her labs, and her wall thickness still being normal at about 1 centimeter, she converted from no uptake in the nuclear scan to very significant uptake, and we started her on treatment. So this was an example where we didn't find it at baseline, but in longitudinal follow-up, we still were able to diagnose it earlier, which is now a paradigm that's being used by multiple centers throughout the country and the world. It's very easy to take a tenosynovial biopsy at the time, and we have several hand surgeons that do this, and we find that this is a way to diagnose it early. And I think I will end there and just state that orthopedic manifestations are common and more common in ATTR than AL amyloidosis, and they're a potential clue to the diagnosis retrospectively, and they can also be used prospectively to try to diagnose it early. I thank you for your attention.